everybody. I hope you all had a good little lunch break, and welcome back. We're going to be chatting about epidemiology and getting an update on epidemiology among HIV, specifically among gay, bisexual, queer, and other men who have sex with men in Ontario. And so the presentation will begin with an introduction to epidemiology, specific attention to the metrics and methods used to monitor the HIV epidemic among gay, bisexual, and other MSM in Ontario. And then we'll be having an update of the epidemiology of HIV among GBMSM up to 2019, and talking about testing, diagnosis, prevalence, and treatment. And as we all know, data forms the backbone of the work that we do in the sector. So understanding its ebbs and flows, the way that people behave, how often people get tested, who gets tested, or who doesn't get tested. And all of that shapes the programming, the services that we offer. It shapes the messaging that we put out into the community. And it can be a touch point for us in terms of measuring the effectiveness in building healthier, more connected communities all across the province. And so I'm really happy to have Abigail Kroch today and Sean Colyer from the OHTN and the Ontario HIV Epidemiology and Surveillance Initiative, OHESI. They're going to be taking us through the most recent published data and are pretty rad data mavens, if I do say so. And so without further ado, I'll hand it over to Abigail.
I think that's the best description I've ever heard of myself, as a rad data maven. So thanks for that. I see lots of friendly faces in the gallery here and friendly names. So it's nice to see all of you. We have a lot of time for this particular presentation. I feel like we're always running through slides one a minute until people pass out. So we're going to try to kind of take a step back and talk about the nature of epidemiology. Some of this will be review for some of you. Some of you will say, wow, they're really taking us back to elementary school on some of these slides. But hopefully the goal is, as people join the sector, that they come up to speed on the type of work that we do. Sean and I are going to be splitting the presentation into two parts. So I'm going to kind of go over what is epidemiology, what is surveillance, who collects this information and why, and an overview of the recent epi trends in Ontario. And then Sean is going to be focusing on specifically some of the more recent trends for GBMSM. Unfortunately, none of this is published, actually. So usually the first question is, are these slides available? And the answer is usually no, because we're waiting to get that publication out. We are in the final throes of the 2019 diagnosis report, hoping to get that out in the next couple months at the latest. So all of the information you see here is from 2019. And then we'll be moving forward with our 2020 analysis, which will be complicated, of course, by COVID. So the questions you have about COVID, how is COVID impacting surveillance? We can talk about those in a more speculative way, but remember that everything we're presenting here is before COVID, which feels like a lifetime ago at this point in time. But okay, so I'm just going to go ahead and share my slides. We're both willing to take questions throughout, so Adam's going to help monitor the chat. You can always also just unmute yourself and jump in, or raise your hand if there's any time you want a clarification or a follow-up, and then we'll leave some time for chatting at the end as well. So let's go ahead and get started. So a lengthy title, and I admire all of you who are willing to come to a slide presentation full of graphs and numbers on a Friday afternoon. We'll try to make it as not as little painful as possible. Okay, so let's get started. So I kind of went over our general outline, but we're going to talk about how we describe epidemiology and what are the different metrics that we use, counts, proportions or prevalent and or percentages, test positivity and rates, talk about the overview of HIV surveillance, and then go through some of the newer information we have about GBMSM that was published in our fact sheet back in June. But this is, I think, our first time presenting it to this audience, at least. There's a lot of really exciting new stuff in there. So one of the things was estimating the number of GBMSM in Ontario. That took us a few years to do using both the Now data and the StatsCan data. We're not going to go through the methods of that, but just provide the number. But there is a blog post on our website that goes through the methods, and we had kind of a multidisciplinary team. Some of those people are here on this call that helped us develop that methodology. And we're actually helping to expand it throughout Canada as well. That allows us to calculate prevalence, which we've calculated for the first time probably in many years, at least 15 years, looking at HIV prevalence among gay, bisexual men who have sex with men. And we're also going to be presenting the care cascade for GBMSM for the first time. So lots of new stuff. So all of the things that you've been demanding over the years, when you say, we need more breakdowns, we need more data, well, you got it. So that just means more slides for us to go through. Okay, so what is OHESI? OHESI, as Adam mentioned, is the Ontario HIV Epidemiology and Surveillance Initiative. It's a collaboration between AIDS and Hep C programs at the Ontario Ministry of Health, Public Health Ontario, the Public Health Agency of Canada, and the OHTN, Ontario HIV Treatment Network. And it's chaired by the Applied Epidemiology Unit of the OHTN, which is essentially myself and Sean and Maya, who's currently on mat leave. This is a very unique situation. There's two things about surveillance in Ontario that are particularly unique. One is that the responsibility for surveillance is not held by the public health agency. So for other diseases, the responsibility for surveillance falls strictly on PHO or on the Ministry of Health. But in this particular situation, the reporting of HIV surveillance falls to this collaboration. We also have a champions committee that we work with very closely, also have many members on this call as well, that helps frame our data. So compared to other agencies doing surveillance, we're much more connected to community, and we do it in a more collaborative way. Usually in other situations, it's just the responsibility of the public health authority to report their numbers. And then the other piece is that we use laboratory-based surveillance in Ontario. So most other jurisdictions use case reports. And if you follow what happens at the public health units, they use a system called IFIS or CCM that relies on case reports. So they get the laboratory positives, and then they do follow-ups. In Ontario, we have both systems operating simultaneously, but for the reporting of surveillance data at the provincial level, we use the laboratory data only. So the data that comes from the public health units is actually through case reporting, but then when we aggregate it up, we use only the lab data. So this is unique to, across Canada as well. So the data that we collect is really meant to inform the Ontario HIV care cascade. So understanding how the data connects to each of the activities we are doing across the cascade of prevention and care. So, we look at prevention activities there. I'm not going to talk about today, but there we might be looking at things like the counts of PrEP, which you can also find in a recent report on our website. We're looking at testing numbers and test positivity, tell us about how our testing programs are operating. And then when we get into diagnosis numbers, understanding the populations that are most affected by HIV, there we use the diagnostic tests and the laboratory enhancement program. And then the HIV care cascade, which kind of gets us through linkage to care, what happens to people when they're in care. And then the ultimate goal of having all people living with HIV able to achieve a suppressed viral load and optimal health. And so the indicators that we present can help inform programs across this entire pathway. All right, I see Sean's putting information in the chat for you all. So if you want to see these reports as we discuss them, he'll put the links there. So where does this information come from? It's really important to recognize that surveillance is not a research project. Surveillance is conducted under the authority of the Health Policy and Promotion Act, the same as it is for other communicable diseases through the reportable communicable disease component of that act. So not all diseases are considered reportable under the public health standard, but HIV is one of those that are considered reportable. And then like what happens like with COVID is they have to expand the legislation to include a new disease as that change happens. But it happens through the clinical setting, essentially. A person decides to get an HIV test, and then the healthcare provider completes the test requisition form. But from the perspective of the person who's receiving the test, they don't necessarily think about their data being aggregated or used. They're really just trying to learn their status. And so it's that relationship between the provider and the person testing that really determines the quality of the data that's collected on that requisition form. So if the provider doesn't talk to people about their risk factors or feels uncomfortable asking people about their race, then that information may be missing on the form. When the specimen is then collected, sent to Public Health Ontario lab, so the Public Health Ontario lab essentially does all HIV testing in the province, at least for now. And if the result is positive, two things happen. Of course, the provider is notified of the result, and the person is notified by their provider. And if the result is positive, it's reported back to the local public health unit for follow-up. Now, given we also have an anonymous testing program, anonymous tests are also reported back to the public health unit, but they don't have the contact information to follow up with the person or recording the information about that person. Secondarily, the result is shared with what we call the laboratory enhancement program, which is run through PHO, where they send a second data collection form to the healthcare provider to collect information that may have been missing on the first form. So when you look at the surveillance data, the data that when we look at all tests, often there's a lot of data missing, but when we look at positive tests only, our data missingness is much lower. And we also know that people may change their responses after they've tested positive. So when they test for the first time, they might say, like, I don't have any risk factors, or I don't want to talk about it. But the result comes back positive, they may be more willing to discuss with the provider what their risk factors were. And so we generally use the information that is recorded through the laboratory enhancement program as a source of truth relative to the first form. But of course, it's all dependent on the sensitivity of how the data is collected and the willingness of the participant, the patient, to provide that information. All of that said, all data has bias and missingness. But this data is more than adequate for us to track trends in the province and to understand where we should be directing our resources. The numbers may be slightly off compared to what a true number is, but the trends, I think, are definitely reflective enough for us to know who in the province should be receiving services. So I'm just showing you what these forms look like and where the information we use is collected. So if you've ever been part of a testing program, you've seen this form before. There's a lot of information collected on the form. Some things on reasons for testing, for example, that's been expanded in recent years to include both PrEP as a reason for testing and a self-test positive as a reason for testing. So this was actually updated fairly recently to when self-testing was approved in Canada. We have previous test information recorded here because we want to know, is someone retesting and it shouldn't count as a new positive, or are they learning their status for the first time? We collect information on sex and gender. So this has been expanded in 2018 to include both trans men and trans males and trans females. And then here I'm showing you the risk factor information. So when we talk about GBMSM, essentially we're talking about people who identified as male or trans male that report that they had sex with men. It's also important to note, like, this is a fairly broad question. when we say they had sex with men, doesn't ask what kind of sex. It doesn't ask, whether it was insertive or receptive anal sex. It's a fairly broad question that is kind of linked to HIV risk. But I think it's purposeful in how it's collected. So if you were to ask more detailed questions about the type of sex acts people are having or the type of sex that was causing risk, you would need to really delve into a research study to be able to do that. Because at the time of an HIV test, people may not want to disclose that level of information to their provider, but it's enough to tell us this is the population of people that are experiencing a certain risk of HIV. And then you can see the other questions are asked as long as it includes sex with women, the use of injection drugs, whether or not someone was born in an endemic country. So an endemic country is defined as a country with a high heterosexual prevalence of HIV, and sex with person so with partner identified risks. So a partner who's HIV positive uses injection drugs or is a bisexual male. So that the bisexual male is really only relevant for a female who's having sex with a bisexual male. So the way this information is later categorized is based on the highest level of risk. And so if someone reports that they are a man who has sex with men and a man who has sex with women, that can report both on the form. The way that person will be categorized is as MSM, because that lends to a greater risk of HIV than having sex with women. Hopefully that makes sense. We can kind of go over it more through the slides as we go forward. And then I think another really important piece, especially, the landscape as we talk about the disparities of HIV and how we see these disparities in other or inequities with other diseases like COVID. We've been collecting race ethnicity data for a long time, since 2009 through the laboratory enhancement program. But in 2018, it was also added to the test requisition form. I think another piece is that we don't ask Indigenous specifically. Indigenous is the aggregation of First Nations, Métis, and Inuit people who respond to those questions. We don't ask any additional information about what nation or band someone is from, whether they have status, whether they have a live on reserve or off reserve. So the race ethnicity question is really questions around perception of racialized groups, not necessarily questions about sovereignty or status. Okay, I'm gonna have to close this shade a little bit more, sorry. All right. So this is where the information is collected, and for whatever it's worth, that's how it's used. I'm also showing you here the laboratory enhancement program form, which is the follow-up form that's done. This form hasn't really been adjusted since 2009, so it's something for us to consider. But a lot of the information that we use to categorize diagnoses happens here. So the same information on demographics, race, ethnicity, reasons for testing, and then HIV test history, again, asking about the date and location of previous tests, and then additional risk factors. And then the kind of new information that's collected is also on the history of antiretroviral use. There is additional information, another form, it's all about the forms, the HIV viral load requisition form, which asks about treatment, that we also include in our cascade analysis, but I'm not going to show you that form. So where all this information gets combined is to really understand who is being diagnosed in Ontario. So people know that people may get tested many times. They may change physicians and get tested for HIV again. And if we counted all of those tests, we would have way more diagnoses every year than actually are occurring where people are learning their status or coming to Ontario for the first time. I think when we look at the total number of positive tests, it's over 2,000. And so more than half of the tests we off the bat we're able to link and say, this person had a previous test using their name in the province. And so we have multiple ways that we try to clean this data. And it's really important to clean it, because if we don't, then we won't know actually how many people are being diagnosed. We won't know, are we improving? Do we need to put additional resources? Like, what's happening? Ontario has always had a fairly lower rate than some of the other jurisdictions that we typically talk about, like New York or San Francisco or London. And so we have a smaller number. We need to really refine it to be able to see whether that number is going down or going up. So when someone has unknown test history, meaning no information is recorded on their test history, we categorize that as a first-time diagnosis. We don't know whether they tested and it was just not included, or whether it was truly the first time that they ever tested in Ontario. So that's what kind of what's categorized here as the unknown test history gets captured in the first-time diagnoses. First-time diagnoses are people who are learning their status for the first time and have no history of other diagnoses and no history of viral load. And we know, like, either they had previous negatives in Ontario, or it's indicated on the form that the person had no prior test history or a test history of negatives outside of Ontario. There are also people who already know their status, but are getting diagnosed in Ontario for the first time. So these people may have been diagnosed outside of Ontario, and it's recorded on their form that they were diagnosed previously in another jurisdiction. So Ontario is a very highly migratory province, lots of jobs here. So people come from all over the country and all over the world, and that includes people living with HIV that are coming here to live or work. We also look at previous viral loads. So if a person had never been formally diagnosed with HIV in Ontario, but has a history of viral loads in Ontario, we assume that they've been living with HIV the whole time that they've been receiving those viral loads. And we actually end up counting them at the time of their first viral load. So this could happen when someone tests anonymously in the province, you know, gets into care, does all their viral loads, and then later they test nominally meaning testing with the name when they change doctors. So that way that person will be linked to a history of viral loads, but we wouldn't have that first diagnostic test. And since we don't absolutely know that that first diagnostic test was conducted in Ontario, we actually do count them. So for anonymous tests, we may be counting people twice. So that's important to consider, but they would be counted twice, probably within the same year or two. I'm just going to pause, take a breath. I know I talk very fast. Does anybody have any questions before we talk more about data? Okay, and I'm hoping Adam's watching time for me.
I am, yeah.
So how do we represent these numbers or this information? We can show the number, so the number of people who tested positive or the number of people who tested. And numbers, I think, are an objective way of measuring something. I know that 5 is bigger than 3. And so it's an important way for us to show things. People tend to think that number, like if I told you it was like 273, that is like, it's to the number of that 3 people, right? So but the truth is that numbers are only accurate within a range. If you wanted to say what was the number of people living with HIV in Ontario, we'd have to be on a specific date. People get diagnosed every day, people moved every day. And so numbers are really accurate within a range. So if you really wanted to count down to the number of people, that's actually quite difficult to do. So if you even consider this talk that we're giving right now, if you wanted to say how many people attended the talk, would we count the number of people who were here when we started, the highest number of people while we were on the call, or the number of people that were here when we ended? So numbers are always accurate within a range. And if someone tells you they know the exact number of something, unless it's the number of Oreo cookies in a sleeve, I wouldn't believe them. So the other piece is that when we have missing data, so for instance, we know that for a certain percentage, for about 25% of diagnoses, we don't know whether or not they were men who have sex with men because that information was missing. So when I tell you the number of MSM, it's an underestimate because of the missing data. And it would be an underestimate relative to the amount of missing data that happened. And so that's also, so in some situations, we do modeling to account for that missingness, and the modeled number is actually more accurate than what I would call the raw number. So especially for breakdowns where there's missing data, that's an issue. We show percentages, that shows distribution within a category. And it's not good for looking at things relative one to another. So 25% of diagnoses occur in females and 75% of diagnoses occur in males. And then when I tell you that about 18% of diagnoses in males are in Black males and 50% of diagnoses in females are in Black females. Sometimes people that interpret that to say like, oh, there's more Black females getting diagnosed than males because 50% is higher than 20%. But it really depends on the size of what you're calculating the percentages of. So when you look at those two graphs, you cannot actually directly compare them without knowing what the total number is that you're comparing there. It can be biased by missing data. So we calculate percentages where known so that we can understand the distribution, accounting for the missingness. But if there's if that information is very biased, like let's say certain types of people are less likely to respond, then that causes an issue when we look at the percentages. And since we don't know the direction of that bias, then that can be a challenge. And kind of as I mentioned, showing those percentages doesn't show you the size of the problem, because when I calculate the percentages within, it could be 100 people compared to 10,000 people, but when you just see those percentages, it doesn't tell you that. And then finally, rates are kind of in some ways the ideal way to look at epidemiological data, but to do that, you need to know the size of the population. And I'll kind of go through this a little bit more, but it includes the context of the size. So if you looked at the number of diagnoses in Ontario compared to the number of diagnoses in Saskatchewan, Ontario is more than 10 times bigger than Saskatchewan, probably a little bit more than that. And so, of course, Ontario is going to have more numbers because Ontario is bigger. So rates allow you to take into account the sizes of populations, to compare across populations of different sizes. They show disproportionate burden, so how many diagnoses relative to the number of people. It also can be an underestimate because we still need to know an accurate count to be able to calculate a rate, and it can still also be biased by missing data. But the other issue that's not indicated here is you have to know what the size, like how do you figure out the size of the population? So there can be real challenges. Looking at males and females and by age and by geography is easy because that's all in StatsCan. But if you wanted to know like the rate of HIV in people who use injection drugs, how do you figure out the number of people who use injection drugs in Ontario? What's the relevant population size? So that can be a real challenge calculating rates. So kind of just taking us back to elementary school a little bit. Here I'm showing you just the number of males, 515 males diagnosed in 2019 compared to 169 females. And then there's some amount for sex, there's not a lot of missingness. But for other categories, there is more missingness. And so when we present numbers, there's always kind of these kind of categories. What's the breakdown within the categories? And then what's the amount of unknown? And often we show those counts in our reports. And actually in our more recent reports that we're coming out with, we're showing them even more and showing the number of unknowns. So you want to look at all of those things to understand the scope. And so here I'm showing you what the numbers have been from 2010 to 2019. So in 2019, there were 687 first-time HIV diagnoses in Ontario. And taking into account, we had some that had missing test history. We believe that this is probably an overestimate of about 5 to 10%. There were an additional 210 people who had previous evidence of HIV, either a test history that indicated a previous test, or they had previous viral loads in Ontario, which led to a total of 897 people who were testing in Ontario for the first time, which we call positive HIV tests. This 687 is the lowest number, not just in the last 10 years, but I think almost in the history of the epidemic, that number has been going down. Another thing that you'll notice is that the previous evidence of HIV has become greater in more recent years. So just the relative size of that bar, you can see it started going up in 2017. I don't know what, like some people say this might be a Trump effect, more people coming to Canada. Ontario immigration has risen dramatically in recent years. I moved here in 2016. So there's a number of people who are probably moving to the province, and that includes people living with HIV coming to the province as well. So it's a good thing that we've put more attention to understanding previous evidence of HIV, because in recent years it has more of an impact. And you can see that our understanding wouldn't be quite accurate if we hadn't taken that into account. And here I'm just showing you first-time diagnoses comparing males and females. So these are the same numbers that you saw on the previous graph. And you can see that 515 is lower than any other bar since 2010. But that 169 is not lower than any other bar since 2010. So the decrease in counts that we're seeing is primarily being, or I wouldn't say primarily, is exclusively being experienced by males. So that takes us to this point here, looking at the percentages. So when we look at males versus females, we can say this year, 2019 was 515 divided by the total, comparing it to 169 divided by total gives us about 75% and 25%. And we always make those calculations of percentages where known. The important thing is to note that these percentages, the percentage could be increasing because the percentage of females might be increasing even though the count stays the same, because the number of males is decreasing. And so that makes it harder to understand percentages sometimes. So when you look here, you can see from 2017, the percent among females has increased, but they're not increasing because the count is increasing in females. It's increasing because the count is decreasing in males. And that's how sometimes looking at percentages can tell you maybe the wrong story. So what's actually happening here in females is that the number is flat while the number is decreasing in males. Makes sense, okay, I hope. I don't see too many confused faces. So why do we care about rates? Rates are the best way to characterize this type of information because it can tell you relative. What if we had a ton of women moving to the province? So the size of the population of women was growing, which is already happening in the province. Like we could expect that our counts might go up just because the size of our population is getting bigger, but the burden of HIV could be going down. So there's many things to consider at the same time. And when we use rates, that helps us take into account all of those things. So the rate of diagnoses among males in the province is about 7.2 per 100,000 males. So that takes into account that 515 and the population size of males in Ontario. And then when we look at females, have a lower number. Male to female ratio is pretty 50-50. And that rate is 2.3 per 100,000. So here we can see, going back, here we can see kind of really what has happened in recent years from 20, and I'm sorry, these about the scale on the bottom, it's the same as the previous slide. So that last one, that number 10 is 2019, and then count backwards to 2008. So the rate in 2018 was 8.1 per 100,000, and it decreased pretty significantly to 7.2, whereas the rate for females between 2018 and 2019 was fairly flat. Because there's actually, and just to mention it, a higher percentage of people who have previous evidence of HIV among females, and the number is smaller, it's harder for us to characterize what's actually happening. We only have 169 females being diagnosed. So if there's, if even 10% of those are misclassified, then it would be hard for us to say whether the number was going down or staying the same. But based on the evidence that we see a declining rate among males and a fairly flat rate among females. You might ask me, why is the rate going down in males and not females? It would be speculative on my part, but I can say at the same time as we're seeing this declining rate in males, we're seeing an increase in PrEP usage in Ontario and in other jurisdictions that has shown a correlation to a declining number of HIV diagnoses. And our PrEP rollout really started in 2017. And in 2018, 2019, we have much higher numbers than in previous years. So compared to a place like San Francisco or London, the PrEP rollout in Ontario was a little bit later. And so it was really when it was approved by the formulary that we started to see more men using it. And Sean probably knows the exact number, but I think it's like more than 95% of PrEP users in Ontario are males. He doesn't have to put the exact number in the chat. It's close enough. Okay, so here we're talking about the exposure categories or risk factors that we showed you earlier. So this is what it looks like here. I'm just showing you males. And so this is the count of the number in each category. And the first we call male-to-male sexual contact with reporting injection drug use. So that would be considered the highest risk group. The highest risk would be maternal to child transmission, but among this population, the highest risk group we report, because that number is negligible, very rare in Ontario. The highest risk category is male-to-male sexual contact and injection drug use. And the next, so these are kind of ordered in order of the hierarchy of risk assigned. You can see there were 23 males who reported both sexual contact and injection drug use, and 284 that reported male-to-male sexual contact. And you can see that number declined from 2018 to 2019. 17 males reported injection drug use alone. 22 indicated sexual contact with a female where there was an identified risk. 38 identified male to female sexual contact with no identified risk, and there were 131 males that reported no risk during this in 2019. So just to be clear, if a person who reported male to male sexual contact also reported male to female sexual contact, only the male to male sexual contact is counted here. They're not counted twice. These categories are mutually exclusive. And the hierarchy is based on known risk of transmission. So I'm showing you here the rate of HIV diagnoses per 100,000 people. So we know that Toronto is the biggest jurisdiction in terms of the number of people. So calculating the rates is very helpful because it helps us understand relative to the size of the health regions. So the northern health region is much smaller in terms of the number of people, but here we take into account the population size. So Toronto does have the highest number of population, the highest count, and the highest rate of HIV among males in the province, followed by Southwest. So this is for 2019. So in Toronto was 21.7 and per 100,000 people, per 100,000 males. And Southwest is 5.1 per 100,000 males, followed by the northern region. So if you only looked at counts here, it would skew your understanding because you'll have many fewer counts in the north because north is smaller. I'm going to switch gears a little bit and talk to you about HIV tests. So here I'm showing you the number of HIV tests that have been conducted. This excludes prenatal testing. So the tests here for females are part of sexual health evaluation, not as part of a routine test. So 333,000 males tested for HIV in 2019, and 325,000 females tested. And you can see that in the past, the females were testing at a higher rate than males. Males experience a much higher rate of HIV. So we're actually happy to see that in 2019, there were more males testing than females. Because the need for HIV testing is higher among males. And you can also see that there's been a dramatic increase since 2014 in the number of tests conducted, with more than 100,000 additional tests conducted compared to 2010. So is conducting these tests telling us more? Here we're looking at the number of HIV tests and the HIV testing rate by age for males. So the number of tests that is conducted is the highest among people the ages of 25 to 29, with a testing rate of 114 per 100,000 males. So younger people do test at a higher rate than older people in the province.
Abigail?
Yes.
That's a quick question. Going back 2 slides to the total number of tests. And just to clarify, that is, so if somebody tested, 3 to 4 or 5, 3 or 4 times a year, it's cumulative, right?
Yeah, so they will be counted more than once. So I should say number of tests and not number of people. Yeah. So with PrEP, we should expect to see more tests being conducted with fewer people. But we can, depending on how people test, we can link those. So if people use their names, we can know how many tests per person. With anonymous testing, we could do that perhaps if they were using the same anonymous testing code. So that's why it is always, we don't actually need to know anyone's name. We just need an identifier that allows us to link the test. So if people are using the same code, that is as good as using name, can even be better if it's entered properly every single time, because names can be misspelled. If you are providing anonymous tests, it is nice for the surveillance to not give them a different number every time. Yeah, Aaron, am I saying your name right?
Yeah, Abigail, I had a question about one of the populations here, and what was in the past slide actually. And I don't work in the clinical side of things, so apologies if this is elementary at all. But when you talked about people who are having a first-time diagnosis who had possibly tested positive before, I was kind of trying to understand, like, qualitatively what that population would look like. I mean, if you take an anonymous test and it tests positive, are they not automatically put into kind of a clinical system, or would those be people who, like, were maybe distressed by their test results and left, and then you hope that they reconnect with care later? Or do you know what I mean?
Yeah, so that's a great question. Most of what we talk about is limited by the data that we have. So we only have laboratory testing data. So we don't have their visits. So we don't know when someone enters care, we only know because they took a viral load. So if someone tests positive in Ontario and then they leave, we don't know what happened to them. We don't know whether they didn't link to care. And actually, Sean will show this later when he shows you the cascade numbers. There's a certain percentage of people who test positive where we never see a subsequent viral load. And let's just ignore anonymous testing, which of course causes, like, has data issues because we can't link those necessarily unless someone's using the same anonymous testing number. So how we track is only through the laboratory testing. So if someone gets multiple diagnostic tests, we don't necessarily know why. If someone is not from Ontario but tests in Ontario, like at an STI clinic, we would count them, but they may go back to their home province for care. And so we can't really say what's happening on an individual level with a person. We talk more about what's happening at the population level, knowing that there will be some misclassification because of data issues. Does that make sense?
Okay, yeah.
Yeah.
That makes a lot of sense. Yeah, thank you, Abigail.
Yeah. I'm not a clinician, but I know that some physicians require, like, if someone already knows their status, they require that person get tested again to be able to give them care. And then some physicians may not, depending on what the practice of the clinic is, which makes it kind of more challenging.
Yeah, that makes sense.
Okay. So this takes us back. So looking at how people reported their exposure category of all the tests. So this includes both negative and positive tests. So this is of, that over 300,000 number. So many, many more tests conducted here, but you can see that there's less information for all of the tests combined. So in 2019, 63% of people who tested for HIV did not report a risk. It's also important to know that the form does not have a checkbox that says no risk. If the person doesn't say any of the risks, it's just left blank. So we don't actually know whether or not the physician asked the person or had the conversation with them or not. We just know that no HIV related risk was reported. So we combine those with no risk reported and unknown. But it's still the case that, so among males, more males are testing for HIV who are reporting male to female sexual contact with no identified risk, even though that is not the highest risk population. It could be that people are not saying accurately how they're testing, but given the number of people who are testing in the province, it's probably the case that a lot of heterosexual men are having HIV tests. And then 13% are reporting male-to-male sexual contact of people who are testing. Does this make sense? So you can see this is a very different distribution than when we look at the positive test. But we don't know whether it's because people without risks are testing at a higher rate, or whether it's just the case that information is not classified properly. But I would guess the fact is that there are a number of people who test for HIV who have low risks in the province. So for that reason, so here I'm just showing you the testing rate per 1,000 people by jurisdiction. So Toronto, again, has the highest rate of HIV. They also have the highest rate of HIV testing. So this is to answer Richard's question. It's not shown here because I'm not showing you females, but there's an equivalent for females where it would be female to male sexual contact. And we would classify female to male sexual contact with a bisexual male partner as an identified risk. So any partner identified risk would be captured under female to male sexual contact with identified risk. So looking at the rest of the regions of the province, so Ottawa also has a very high testing rate, especially relative to their number of positives. So Ottawa, if you recall, did not have the second highest diagnosis rate, but they have the second highest testing rate in the province. This may have something to do with the fact that they've seen declining rates of HIV in recent years. So I think Ottawa is an interesting example for the rest of the province. But you can see that among males in 2019, fairly, if we think of just outside of Ottawa and Toronto, fairly similar rates of HIV testing. So how we use the information to look at like how are we properly targeting HIV testing in the province, we look at test positivity. And so test positivity is the number of positive tests divided by the number of total tests, and taking the percentage, so times 100. It helps us understand whether testing is targeted to high-risk people. So if only high-risk people were testing, you expect a very high test positivity rate. If lots of people are testing you have a generalized testing population, so people are getting tested for HIV all the time, but they actually don't have high risk, you would expect a low test positivity rate. So Ontario so if you look at BC, for example, which has kind of a generalized testing strategy, you would expect a low rate. Ontario, which has a more targeted testing program, you would expect a higher rate of test positivity, but it's very difficult to interpret because you have to take into account the volume of tests that are done and the number of HIV diagnoses. So if the number of tests you were conducting stayed the same, but your HIV diagnoses went down, then your test positivity rate would also go down. So there's many factors to consider simultaneously when you look at test positivity. So you kind of have to look at them all together. Okay, so I'm showing you here that we've saw that really dramatic increase in testing. At the same time, we've had a decrease in test positivity, and that decrease has been specifically in males, much more than in females. So in 2010, started with a test positivity of 0.35%, and that's down to 0.15% in 2019. And here we're looking at who is most likely to test positive. And so this is, of course, when these risks are reported, what we see is that men who report that they had sex with other males and used injection drugs have the highest test positivity. So that group is a very small group of men, but they have a higher test positivity than other people who report other things. So and then male to male sexual contact, which we tend to call MSM, they have the second highest positivity rate. So people who report risks, they probably test for HIV more regularly. They are more willing to maybe report their risks. Those are the people that have higher test positivity. So when you're talking to people, knowing that people are telling you, you know, I have sex with men and I use injection drugs, those are people you really want to get tested, because that's where we see the most test positivity. Yes. And that's the other piece here, is that these are very limited to the exposure categories. So here we're looking at injection drug use, but how does that expand to other men who use drugs, which I think is very relevant for GMSH's PNP and chemsex, where injection drug use may be only one mode of use of drugs, but it could be the case, and I think it's well established in the literature that the use of drugs increases HIV risk. And so how does test positivity differ by region in the province? So Toronto, again, also has the highest test positivity rate. So highest rate of HIV, highest rate of HIV testing, and highest rate of HIV test positivity. And you can see that Ottawa, which had the second highest rate of testing, actually has almost among the lowest rate of HIV test positivity. So what this tells us really is that so even though we're doing a lot of testing in Toronto, we probably could do more testing in Toronto because the test positivity is so high. I think this is my last slide, and then we can take maybe a quick break or just a breather, and just showing you looking at the overall priority populations in Ontario. So there are a number: gay, bisexual, other men who have sex with men, people who are African, Caribbean, Black, people who use injection drugs, Indigenous peoples, women, and then we also have those people who are not in a priority population and people where it's unknown. And so here I'm showing you a lot of information at once. But let's just look first at the GBMSM. So GBMSM made up 64% of first-time diagnoses in 2019. So that includes both men and women in the denominator. And that was 307 diagnoses with first-time diagnoses, with an additional 70 diagnoses where previous evidence of HIV. So there are both people who are identifying as GBMSM who are being diagnosed for the first time, and also people who are newer to the province as well. And GBMSM remains the priority population with the largest number of diagnoses and the largest burden. Okay, so we take 5 minutes?
Yeah, let's do 5 minutes. We'll come back right before 2 o'clock, and we'll hear from Sean. And then once Sean's done, we'll have some time to have some additional questions and discussion. So we'll see everyone back in a few minutes. We will get started, and I'll turn things over to Sean.
Thank you, Adam. Thank you, Abby, for that great intro. I actually learned some things also myself with that, which is a good thing. So I'll go ahead and share this. So with any luck, you're seeing the full screen slide now of our second half. As it's been said, I'm doing the update of the epidemiology specifically among GBMSM in Ontario. So some of these slides may look similar to what we saw before. A lot of what Abby presented was males in general, so all the males, whether it was testing or diagnoses. Now we're going to zoom in a bit within those males to the gay, bisexual, and other men who have sex with men. And of course, as before, any questions or comments, shout them out or leave them in the chat. I do find when I'm sharing screen on Zoom, it's not great of alerting me of chat things, so feel free to just stop me anytime. In the interest of time, we'll jump right in. So the first thing we want to do with any population is specifically define it. So what do we mean when we say gay, bisexual, and other men who have sex with men? There's a lot of kind of overlapping definitions out there in our sector, and they all kind of serve their purposes. GBMSM, as we call it, is one of our priority populations. So populations made a priority for programming and funding by the Ministry of Health in Ontario. We see the other ones there. I imagine we're all familiar with these for the most part. And then an ideal world, or what GBMSM is really meant to be, is capture a comprehensive sociological kind of community, a more holistic definition of men who identify as gay or bi, and other men who have sex with men. So a really kind of community holistic view. But when it comes to kind of the cold, hard, raw data that we've been looking at already so far, we need to really specifically pinpoint what do we mean by that. So with all the slides we'll be seeing, GBMSM are defined by indication of male sex and also sex with men as the risk factor, which we saw in the forms before that Abby shared. So that's what, it's kind of a strict simplistic definition, but it does get at what we're after here with the population. So one of the exciting things we mentioned before is our estimation of just how many GBMSM are living in Ontario. This was a fair bit of work, and I put the methods, and I'm happy to do it again, but for this estimation in the chat. Basically, we use data from the Canadian Community Health Survey that comes from StatsCan and from SexNow, which comes from the CBRC. Data between 2017 and 2019. So at any point over these 3 years, we estimate the number of GBMSM living in Ontario to be 270,922. As Abby said, she made the good point, if anyone's telling you a number and they're super confident, there's exactly, 922, it's kind of laughable. Of course, we're not certain it's exactly this number, but it does give us a good kind of reference point to work with. And we'll do that with the prevalence further on. Basically, roughly shy of 218,000. So that's a big number. How do we kind of conceptualize that? It represents about 4.1% of all adult men, defined as at least 15 years of age or older in Ontario. So that's about 1 in 25. And I also looked up, I was saying, how do I kind of relate this to a city? Apparently, it's almost identical to the population of Windsor in Ontario. Not the whole metro population, but the city of Windsor, which I thought was an interesting reference point. Then I thought of a whole city full of gay men and I got distracted, but we'll keep going with this here. So before we get to diagnoses, we'll touch on testing, which we saw some already, but again, this is specific to GBMSM. So we may ask, what proportion of HIV tests in Ontario among males are attributed to GBMSM? So in 2019, we see that number is 35%, just over a third. And that's risen over these past 10 years from about 20% 10 years before. So basically it was about a fifth in 2010, it's risen to just over a third. So if you remember, Abby had a slide that had all the unknown, and that was the biggest one because as she said, we have more unknown with tests than we do with diagnoses if someone tests positive. So basically when we remove all those unknowns and you ask me, okay, Sean, where you knew exposure category, how many were GBMSM? Then I'm able to say to you 35%. So we represent just over a third of HIV tests among males specifically in Ontario in 2019. And then kind of also relating to what was said before, so what about diagnoses? What portion of first-time diagnoses to GBMSM account for? This, as we see here, is about 80% in 2019, just shy of, and this one really hasn't changed too much over time. It varied between about 75 and 80%, but really has been fairly steady. Again, this is among males specifically. So about 4 to 5 tests, diagnoses, males diagnosed for the first time with HIV in Ontario were GBMSM, basically reported sex with men as an exposure category. And then what about numbers? So what are those percentages, that 80%, what number does that represent? So again, Abby made the good point before, anytime someone gives you a number, certainly a specific number, we want to kind of think about that a bit. So these are actually estimates, and you may also recognize this number is different than what Abby reported before. I believe it's 307 she reported before. Basically, that's where we know certainly GBMSM status, but doing some simple estimation process, and we can talk about that, of course, but because a certain percentage, we see at the bottom, 17.6% of diagnoses, we didn't know whether they were GBMSM or not. And we know, at least some of them are. From the last slide, it tells us about 80% of them are. So basically using that math, we're able to say an estimate, and we're not swearing by this number, that's why it's an estimate, but the realistic number is more around 391 first-time diagnoses among GBMSM in Ontario in 2019. And this number, as we see, is kind of trickled down. Was a fair bit higher 10 years ago, 487 in 2010, came down, it kind of hovered around 420 for about 8 years there, 7-8 years. And then in 2019, it more substantially fell. And as Abby mentioned already, we're thinking that probably at least has something to do, at least hopefully, because there's been so much effort put into PrEP, but it's probably partly explaining that. But when we take these numbers and we say, well, how is this, as Abby well explained, how does this relate to the overall population? We know the population is actually increasing over time. People are immigrating to Canada and Ontario all the time. People like my sister are getting pregnant and having kids. So the population is always growing. When we consider these numbers relative to a growing population, we see actually even maybe a little bit more of a substantial decrease or improvement over time. So 10 years ago, we had 7.6 diagnoses among GBMSM for every 100,000 males in the province. And then over time, that's come down, kind of a similar pattern, more of a decrease in these first 3 years, a bit steadier in these middle years, and then a more substantial drop in 2019 from 7.6 to 5.4 overall. So that's where we see kind of the truest state, at least overall, of what's happening with GBMSM when we consider the population change that's happened. Also, we're only able here, Abby made the point, it's easier to look at StatsCan and they can tell us how many males are in Ontario in any year, right? So that's what we've done here. What is trickier to do, how many gay, bisexual, and other men who have sex with men are in Ontario every year. That's what we've estimated, but trying to do that to get a more specific rate is trickier. But this at least gives us a proxy measure, I guess assuming that the same proportion of males is GBMSM every year. Also keeping with rates, so when we look at different age groups, this is all within 2019 now. So when we take the number of diagnoses within each age group, again, these are all GBMSM, and divide that by the number that StatsCan tells us of men of a certain age group, we can get rates. And then we can really compare apples to apples, like a control for the different population size of different age groups. So we see higher rates, probably not surprisingly, in the younger age groups. 30 to 34 had the highest rate, 14.6 diagnoses for every 100,000 males aged 30 to 34, followed not too far behind by those in their late 20s at 13.5. So I think that's one of our takeaways here, certainly that younger guys are having higher rates of diagnoses. But another one I wanted to mention is it's, not just the younger guys. We're certainly seeing substantive rates in other age groups, and including older age groups. Those in their late 50s still had rates of 3.8. Late 40s as well, 5.9. So it's a bit of a broad distribution, although it has its peak as well. And then when we look at exposure category within GBMSM, so as we noted before, GBMSM is basically only defined by the two exposure categories. So because of the hierarchy and what Abby mentioned before. So we know, of course, to be part of GBMSM, we were reporting male-to-male sexual contacts. So all of our diagnoses among GBMSM are, of course, reporting that. The question becomes what proportion are also reporting injection drug use? I think this came up a little bit as well when we looked at males in general. And then the same phenomenon is going to happen here with GBMSM. So in 2019, we saw about 7.5% of diagnoses among GBMSM also reported injection drug use in addition to male-to-male sexual contact. That's about 1 in 13, 1 in 14. So certainly sizable and worth noting. It hasn't really changed too much, at least over these 5 years. It's been fairly steady. Maybe you could argue it dipped a little bit in 2017 for whatever reason, but it really isn't too remarkable. So a consistent about 1 in 13, 1 in 12 maybe of GBMSM diagnosed with HIV are also reporting injection drug use. Does that relate to crystal meth that was mentioned before? Quite possibly. Opiates as well, of course, another possibility. When we look at the ethno-racial distribution, this is one of the more, I think, noteworthy things to take home with us maybe. So right away, we can probably see these are counts before we get to percentages or anything else. So the absolute counts of diagnoses of GBMSM diagnosed with HIV for the first time. So we can see the numbers in white guys, white GBMSM are decreasing. And you may think these kind of blue lines, we just kind of eyeballed, or I just had fun in PowerPoint. Sometimes I do have fun in PowerPoint, but these were actually made with linear regression. So if you remember kind of your grade 10 slopes and all that fun, basically we use statistics to draw these. And what we're able to say from that is the change among white guys is statistically significant. So the number of white GBMSM being diagnosed with HIV for the first time is decreased over these 6 years. And then the other race ethnicities, there's certainly suggestion of some change here, especially among Black guys and Latin Americans. And I think that corresponds with what Adam was saying. You guys are seeing kind of more on the front lines. It isn't statistically significant, but the takeaway we can say from this is diagnoses are decreasing among white guys, but we can't say the same among guys of color or all these other race ethnicities. And then when we think back, we were seeing those improvements or decreases in the earlier slides. It turns out largely these are because white guys are decreasing and the other ones basically are not. So that's one takeaway we want to, I think, take from this presentation probably. And part of the reason this may not be significant is lower counts, and there's a whole math talk to talk about that. So we want to keep this in mind, but contextualize it within smaller numbers than white guys, but certainly not the decreasing trend that we're seeing in white guys. When we take this and look at percentages, so we're going to kick out the unknown and then put the rest together and see what portion of the pie each race ethnicity accounts for or makes up. It kind of corresponds that we're seeing white guys, because their number is dropping, their portion of the pie is shrinking as well. So they're no longer a majority, they're just under 49.1% in 2019, versus before, you can see about 5 years ago, they were over 60%. By they, I should say we are over 60%. But now we're less than half. And then we're seeing, if one is decreasing, the pie is the same size, the rest are going to take up a larger portion of it. So we're seeing Latin Americans largely and Black GBMSM take up a larger portion of the pie of GBMSM diagnosed with HIV for the first time, both around 15%. Again, stop me anytime, but hopefully we're all making some sense here. And we can go back to any of these at the end to discuss. When we look at health regions, hopefully most of us are able to kind of identify from this where our respective place of work is. So we have Northern, which we had to chop off here to show. That always pains me to do that as a Northern boy, but I think we're used to it. And one thing I wanted to point out, Central East here does include Peel. So that includes Mississauga and Brampton. So most of the Toronto suburbs are actually in Central East. And then Halton, which includes Burlington and Oakville, that's where Central West starts. It also includes Hamilton, Niagara region, Guelph and Kitchener. So we can go back to that as well, but I think we have a handle of what region each of us is in. When we look at, again, we start with counts. As Abby said before, Toronto is where the people are. We also know higher population of GBMSM there. So we have by far the highest counts here, 202 in 2019, but counts elsewhere as well. Central East being that kind of GTA area that excludes Toronto, being second with 36. So when we look at these and we take them all and we spread them all across the regions and we say what portion of the diagnoses were in each region, this is our next slide. I'm able to say those 202 diagnoses, they represent 66% of all the diagnoses in Ontario. So if you're asking me what's the breakdown of diagnoses attributed to GBMSM across regions, this is what we get at here. So this is good to have a provincial view and you say, how do all the GBMSM diagnoses break down across the regions? So 2/3 in Toronto, we actually saw quite a substantial, not huge numbers here, but a trend in Ottawa. They're doing quite well with the counts. I forgot to mention that here, counts as well, and then the percentage just reflects that decreasing in Ottawa. And then about a bit over 1 in 10 were in Central East. That's that GTA area. Central West, which was the Hamilton, Kitchener, etc., was also about 1 in 10, but a bit less. So that's the breakdown there. But then you might ask me, and this is what I'm wondering is maybe more useful to this crowd. If you're in a certain region, you may ask what percentage of diagnoses in males in my region were GBMSM? So it's a different question. So I can say here 66% of all GBMSM diagnoses were in Toronto. If you're asking me how many diagnoses in Toronto were GBMSM, then it's actually higher. And this is what we see just for 2019. And this is shaded to correspond with these numbers. So in Toronto, 81%, so just over 4 in 5 of males diagnosed with HIV for the first time in 2019 were GBMSM. Actually, the highest was Eastern Region, which includes Kingston, at 83%. Interestingly, what I mentioned before, this kind of GTA writing, I guess includes Barry, Aurelia, and some Muskokas as well, quite a bit lower. Only 39% of diagnoses in of males diagnosed with HIV for the first time were GBMSM. So they may likely have a greater portion being attributed to other risks, whether it's injection drug use or heterosexual sex. And the other ones are kind of intermediate, Northern 71, Southwest 59, and about 2/3 in Central West.
And we've just got a question around if folks go into Toronto to get tested, test positive in Toronto, but live elsewhere, how does that factor into this map?
So that was my exact same thought actually this morning, because I'm sure that's a phenomenon where, a lot of guys maybe live in Pickering or something or coming into Toronto. But for the most part, and Abby can correct me, the region is assigned based on the address of those being tested. And I think in the rare instance where it's not, then it's the provider address is used. But I do believe that's a fairly small proportion. I think most of them are based on the address of the individual being tested. So that doesn't really become a good explanatory factor for this.
Perfect, thanks.
For better or worse, I guess. So to kind of summarize all of this here, in 2019, GBMSM made up about 4/5. Like we said, it was about 79-point-something% among males. Estimated number of first-time diagnoses attributed to GBMSM decreased to 391 from 487. Oh, the other things are going in a different order here. Okay. 7.5% of first-time diagnoses attributed to GBMSM reported injection drug use, and that's fairly constant over time. We rearranged the slides without rearranging the points. So just remembering the age distribution was higher in the younger guys, higher rates in those aged 25 to 34, but non-negligible rates certainly in older age groups, even as high as 60s and 70s. But 2/3 of diagnoses attributed to GBMSM were in Toronto. And then within Eastern and Toronto regions, they had the largest proportions of their diagnoses that were GBMSM. A bit over 4/5 there, 83 and 81%. And then lastly, I think one of our take-home points may be between 2014 and 2019, white GBMSM made up the largest number of first-time diagnoses, and they still are, by far the largest number. So we don't want to lose track of that. But this number decreased over these years, and while GBMSM of color did not have the same decrease. And yeah. So moving along, we've talked about testing and diagnoses. Now we get into the care cascade, where we're basically managing those living with HIV and working towards best outcomes. First, we want to define a prevalence. So I imagine most of us, or a lot of us may know this already. It really is just a specific type of proportion. So we just take a certain population and say, what proportion of it are living with X disease or have any factor really. So, at any given time, how many people have COVID, how many people in Manitoba have diabetes. We're just saying what portion of GBMSM living in Ontario are living with HIV. And that's what we're able to get at here. And as Abby said, I think earlier, this has been estimated before, but not for some time. And I think with quite different methods. So we're able to speak to it, we think a bit more confidently and with a bit more nuance maybe. So our number is for 2018 because it's based on our cascade numbers. So basically we estimated 10,909 GBMSM living with diagnosed HIV. We want to reinforce that it does not include those living with HIV that have not yet been diagnosed. And we divide that by the 217,922 we estimated to be living in Ontario. We get a prevalence of 5%. And maybe you saw this earlier in our fact sheet that was published in June, but a fair bit lower, I think, that was been reported historically. And again, it doesn't include those living with HIV, but a very useful number still in 2018. Sorry, it doesn't include those not yet diagnosed. We don't have too much time, so I'll keep going here. One point we want to make when we look at the care cascade, and we basically define a cohort, but in order to define that, specifically in regard to GBMSM, we have to know basically two things. You have to have provided your name so we can link your data, and you have to tell us that you're sleeping with men, right? So if you're not going to report either of those things, we're not able to include you in this cohort where we estimate care cascade outcomes. So we know, Abby mentioned before, nominal tests are where you provide your name, and about 76% of tests were nominal. People provided their name. So for these specific for GBMSM, or if we're looking at people who use injection drugs, we need to know these factors to include you. The overall cascade numbers, we don't necessarily need to know that because they're just broader kind of overall numbers. We're not getting into the details of defining these kind of subcategories. So the numbers in the following slides are where people tested nominally and informed us of their MSM exposure, that they're having sex with men. First one is among those, these are all among those, among GBMSM diagnosed with HIV. This one is what percent were in care. So 91% with respect to GBMSM versus if you compare that to all those that were tested nominally, so all those that provided their name, whether they're GBMSM or not, was a very similar percentage less at 90%. And that's been fairly steady over time. I think Abby alluded earlier that, you know, we have a certain percent that were not linked to care, and this is what she means. It's about 9%. So the rest of this here that have been diagnosed with HIV, but as far as we can tell are not linked to care, and there could be some reasons for that. Secondly, we asked of that same population, GBMSM diagnosed with HIV, what percent are on antiretroviral therapy? This one, we see an improvement over time, or an increase from just shy of 70% 10 years ago in 2009 to 2018, 87%, and very similar to the overall nominal testers. And then lastly, same population of GBMSM diagnosed with HIV, what percent were virally suppressed? It's about 85% in GBMSM, and a smidgen lower in all those that were diagnosed nominally, 84%. This one we've also seen, I think, even more improvement over time, from about 2/3 10 years ago to 85% in 2018. And then many of us have probably heard, I'm sure, of the UN/AIDS 90-90-90 targets. So how are we doing on those? We do our best here to relate this to GBMSM. The first one is not GBMSM specific. We don't expect it's wildly different, but overall, actually PHAC estimates 85% of those living with HIV to be diagnosed. So that leaves, what is it, 14.8%, what we call an undiagnosed fraction, or not yet diagnosed with HIV. About 82, we estimate a range of 82 to 87% of those diagnosed. This one is specific to GBMSM, we're on treatment. And about 98% of GBMSM on treatment were virally suppressed. We know the meds work, so that one makes sense. And then how are we doing with being linked to care? Of course, we want these to be, you know, as quick as possible for everyone's sake. Time from diagnosis to care, the median time after diagnosis to the first viral load tests, it's only 14 days for GBMSM, a little bit quicker than overall, which is good. And 72% of GBMSM were linked within a month. So we're quite expeditious that way, which is good. Time from diagnosis to suppression, median time to viral suppression was 104 for GBMSM versus 119. So again, we're quicker. We walk quick and we get suppressed quick. And 70% of GBMSM were virally suppressed within 6 months. We're getting 7 and 10 within half a year. And then what we mentioned before, 9.5% of diagnoses cannot be linked to a viral load test, meaning they're not in care, which is lower than overall. So that's good for GBMSM. And there could be issues there with linkage. I think Abby mentioned this before, you know, if you're living in maybe Gatineau or something, or cross-provincial borders that could have issues, or maybe you've been diagnosed and you've just never gone into care. And that remains work for us to do. I think this is the last one here. So we can estimate GBMSM care cascade among nominal testers, only who report, so you have to test nominally and report exposure category. That's what these are among. The care cascade for GBMSM has improved over time, especially the percent on ART and the percent virally suppressed. In particular, we need progress on getting GBMSM on antiretroviral therapy. So we have, a good number in care, but it drops a bit when getting them onto ARTs. And when on treatment, as we know, GBMSM reach and maintain viral suppression, because we know treatment works well and we're doing well there. I want to say, yeah, that's the end. I'm hoping there's a bit of time left for questions for either Abby or I guess.
Yeah, there are a couple. And I guess there's a few that have come in around the relationship with, the rollout of self-testing, and that, you folks had commented on not on using lab confirmed tests. And so, I wonder what connection there is to either point of care or self-testing, and how, if we could imagine for a minute how we might be able to capture those numbers of people who might have a positive point of care or self-test, but may not have done a lab test.
So it depends on what program people are using, how the data is collected, but the point of care program that's run through the ministry, and that's the vast majority of point of care tests that are done in the province. All of those are tracked through Public Health Ontario, and there are very few people, I think almost none, where we see someone had a positive point of care and did not have a confirmatory test. For the so I think that's been well established for many years, and Ken is on here, so he can also comment on that. But we do only count confirmatory tests as positives, as there is a false positive rate for both of those testing modalities. For the self-testing, we're very interested in seeing like how many positives we're capturing through self-testing, and so that's why that information was added to the requisition form. And of course, we work very closely with our Get a Kit partners at the OHTN. Used to be down the hall, now just down the Zoom. But we keep track with them of how many tests they're seeing and how many positives they're seeing as well. And I think they're doing a great job of making sure people get linked and get confirmatory tests. But of course, like as self-testing expands and people start going down to shoppers to get the tests and not using these programs, it's not possible to monitor all of the self-tests that are happening in the province. But some might say that'll affect our understanding of our testing numbers, where people are less likely to go in and get a test and more likely to rely on the self-test. So I think we can kind of see what happens as that expands out. But we are the only jurisdiction that monitors testing, and it's because we have a single site of testing. So because Public Health Ontario is conducting all of the tests, that allows us to be able to look at things like the testing rate and test positivity. Other jurisdictions actually aren't able to do that. So I think it's just a question of looking over time, and maybe also using some of our other resources like the Sex Now survey to see, like, hopefully adding some questions there about self-testing to know how many tests might be happening that we are missing in the community. So we can rely on other resources to help us understand the surveillance data.
Thanks. And yeah, that's such a great point on the input opportunities around things like Sex Now, where when like folks on this call are pushing out Sex Now in the community, that it will have a direct impact on the numbers, on our ability to report on numbers that we see here, which in turn loops back into us and then affects our programming and communications decisions. So it's neat to see that sort of full cycle, like, post about Sex Now, get people in the community to fill it out. It factors into this data, we get these presentations, and then we can make decisions going forward. Well, let me take one last question. It's 2:30. Which is around 2020 data. And I know that you folks have had it on your minds. So is there any sort of parting comments you want to make about it so far?
We're crunching the numbers now, and so we'll be working on producing a report shortly. And that's basically all I can say about it. But the 2020 data, I think, is going to be difficult to interpret. We know that this has been presented already elsewhere, but our testing numbers have gone down. People's risks also went down. And so what does it tell us about the trends during a year where it was just such an anomaly, where we have fewer tests, but certainly fewer fun activities going on in 2020? And so what risks were occurring relative to the numbers? We'll kind of have to think about it in a completely different like time capsule rather than considering it as part of an overall trend.
Yeah, fair enough. All right, well,
I
thank
can
you both
just
very much.
Add
Oh,
one
Sean,
more
did you
quick
wanna-
point. Sorry, just with the 90-90-90, one thing I missed saying was as encouraging as that last number is, basically to achieve it, we have to achieve all three. So certainly we're doing well with the last point, but it's kind of a all or nothing because they have to do with each other. So lots of work ahead for us, as much as success behind us, I guess.
All right.
If anyone ever needs any data, please reach out to us at OHTN.on.ca. Please join our mailing list, also at our website, www.ohesi.ca. If you join the mailing list, you will get reports the day that they are released, and you don't have to wait until someone else sends it to you. So we will be sending everything out through there. If you ever have questions or need data for grants or reports or things that you're trying to figure out, don't ever hesitate to reach out to us.